My name is Dr. Edward Ngwenya, and we continue with our plastic surgery podcast. Today we will be discussing prominent ear pediatric, and both adults. So let's go right into it. By the way, as I always mention, this assumes that there is knowledge to the listener, and this does not serve to replace your learning, but only to augment it. So, what is a prominent ear? Well, let's look at our classification of the type of ear pathology that we can get. So as per Marx and Tesna, they basically described abnormalities of the ear. And what we generally commonly use is the Tesna. Of course, there is Marx classification, which divides the congenital ears into grade 1, grade 2, grade 3, grade 1 being an abnormal auricle with all identifiable landmarks. So the auricle is abnormal, however, the landmarks are all identifiable. Grade 2, the auricle is abnormal, however, the landmarks are not identifiable. So it's abnormal auricle without some identifiable landmarks. And then grade 3, of course, will be very small auricular tag or anosia, as we'll see. But generally, what we'd also want to know, would like to know a more detailed classification. And the one that we would like to hear as examiners would be the Tenza classification. And the Tenza classification divides ears into type 1 to type 5. Type 1 being anosia, where the ear does not form. Type 2 being a completely hypoplastic ear, that is microtia. And we divide type 2 into type A and B. A being microtia with atresia of the external auditory meatus, or canal rather. So what we're doing, we're going from the worst to the better. And type B will be without atresia of the external auditory canal. And then we've got type 3. Type 3 now is hypoplasia, but not complete hypoplasia. It's hypoplasia of the middle third of the ear. Type 4 then becomes hypoplasia of the superior third of the ear. And that we will then divide into 3 groups, A, B, and C. Type 4A being a constricted ear. It may, and those have their own variation. It may be a cup ear, or it may be, extreme where it may be a lob ear. And then type B is cryptotia. And you would see that's the ear that's hidden underneath the skin there. So that's cryptotia, which is hypoplasia of the superior third of the auricle. And type 3 is hypoplasia of the entire superior third of the ear. So that is type 4. And then the last type, which is the focus of today's discourse, is type 5, which is the prominent ear. So the question then you may ask me is, what is a prominent ear? And generally, what must come out and what you must know are the 3 main abnormalities of a prominent ear deformity. And this herein focuses our approach into the correction therein. So the 3 deformities or abnormalities that we identify in the prominent ear will also guide our approach into the 3 things that we need to repair when we correct this prominent ear. Now, what are those 3 things? The first is the loss of an antihelical fold. So these patients have an underdeveloped antihelical fold. That is the first abnormality that may be there. 2 it's the conchal excess. So they have what we may call an overdevelopment of the conchal wall or bowl. And this we characteristically define by our angles that we measure. And this would be interpreted as an increased conchomastoid angle greater than 90 degrees, because the general we know should be 90 degrees. If it's increased, there's an overdevelopment of the concha. And then the last being, when you look at the increased conchal angle or the scaphoid, the conchoscaphoid angle, it would generally be increased greater than 90 degrees. And this would then generally be the cause for not just the loss of helical fold, the helix that becomes prominent, but the cause of a prominent earlobe. So they have a prominent earlobe, an underdevelopment of the antihelical fold, and overdevelopment of the conchal bowl. They may have some or all of these characteristic abnormalities. So that defines a prominent ear. Therefore, when we repair a prominent ear, we need to then look at that and define our goals for orthoplasty. So when we ask what are the treatment goals of orthoplasty, which is correction of the ear, generally what we then want to do is get this abnormal prominent ear to as good as normal as can be. And so what do we want to do? We want a correct placement of the ear. That's the main thing. We want bilateral symmetry. I mean, you don't want an ear that's now, under-corrected or over-corrected versus the other one. So we are chasing for bilateral symmetry. Now, also, another thing that we chase for is the position of the two ears. That, this being the distance from the lateral borders of, to the head, they should match fairly closely within 3 millimeters at any given point. So that is our guide for positioning. And so when you look at the protrusion of the ear, what we have are normal helix to mastoid distances that we can then look at 3 points. And that is a guide that one can use in order to achieve a normal non-prominent ear. And what are those? We can divide it, the helix to mastoid distance, from the upper helix, the middle, and the lower third. Now, the upper third, the helix, upper helix, we want a distance from the helix to the mastoid distance of 10 to 12 millimeters. In the middle, we want it 16 to 18 millimeters. And in the lower third, 20 to 22 millimeters. I'll repeat that. Upper, 10 to 12. Middle, 16 to 18. Lower, 20 to 22. As you can see, there's a 2 millimeter variation, gap between the two. And generally that comes to what we said, that we want them to be, to match closely within 3 millimeters, at least, of any given point. What are our other goals? We want the visibility of the helical fold when viewed from, when you view someone from the front. So we want to have this visibility of the helical fold, and we want to see the antihelix when we look at the person in an anterior view. The helical rim, we want something that projects laterally further than the lobule. That's an important criteria as well. And of course, our correction, what's ideal is that we want a smooth, rounded, and well-defined antihelical fold, as we've mentioned. But smoothness, well-rounded, is the key to what we're chasing. Of course, I've given you different angles that we target and that are within the normal. So then we would chase for a concoscepal angle of less than 90 degrees, as I've mentioned. And perhaps another, the last two things we can look at would be conchal reduction, or rather the reduction of the concoscepal angle, which I spoke about, that's 90 degrees. We want to reduce that. But what we want is we do not want to see a marked distortion, or rather, can I say, we don't want to see a decrease in the depth of the post-auricular sulcus. That's what we want. We want it still to be defined. So now that we've defined our aims for surgery, what are the ways that we can manage or correct a prominent ear? And herein we can divide our approach from surgical to non-surgical. Now, very early in life, within the first 72 hours of birth, if you can pick this up, cartilage molding techniques, or rather molding techniques, are what we chase. If you can see this within the first 72 hours, the options therein, we would then want to splint the ear. So there's different splints, custom versus commercially available, like the ear well. You can, instead go for taping. Others have described gluing the ear. And these are ways that the cartilage is still soft, it's moldable. And so if we come in and apply these techniques within the first 72 hours, performing it continuously, by the way, for 6 to 8 weeks, we may avoid surgical treatment for this patient. And this is the best. Why I say first 72 hours? Because this takes advantage of the circulating maternal hormones that results in a more, let's say, pliable and malleable cartilage. And so we are able to then mold it into the way that we want it. However, if you've missed the boat, then we're going to have to look at other techniques. You've got a child who's 6 years old, you've got an adult, different story. That's not going to work. So now we need to look at surgical procedures. And with surgical procedures, we can group them into 3 groups. We can put them into cartilage molding or shaping procedures, and we can then, those will involve suture techniques, and we'll go into those. The type of sutures we can use for the antihelical molding being the Mustardi sutures, the type of sutures we can use for the cartilage molding, the concha, being the Fornes sutures. Now, then there's also scoring techniques that we can use that can assist us in molding these cartilage, the helix and the concha. And these basically are abrasive techniques which follow the Gibson principle. Now, the Gibson principle is based on an observation that cartilage curls away from a cut surface, and this has been attributed to the interlocked stresses that are released when the perichondrium is incised. So when you incise the perichondrium and the cartilage, the cartilage then curls away from the area which you are scoring. And so as we've defined already, you can understand that where we are going to score is anteriorly, never posteriorly. It would be for the antihelical fold performed on the lateral anterior surface. So there are various procedures. We'll go into that, from Stenstrom, cartilage scoring, and I think I struggled with that name. Let me remember it. Concret, CHONGCHET scoring, procedures. These are just some of them that are defined. But Scoring procedures, suture procedures will fall within this group of cartilage molding. And we love those, especially in kids. The younger they are, the better the cartilage. It's still softer than now an elderly patient who the cartilage is much harder and may not comply. However, we understand what you must tell the parents. The outcome looks beautiful. It's smooth, a good product that you get at the end. However, the recurrence rate is high. In fact, as high for suturing alone, it would give you 24. Others have noted 10% if you add the scoring techniques. But we know within 6 months, as the literature has it, generally these patients may return with a recurrence. This is one thing we must know. Then the other group is cartilage excision, or others would say cartilage breaking techniques, as per Converse and Woodsmith. And these generally, this is when we now cut our cartilage. Basically, it will give you, your sharp appearance. I think it looks ugly, sharp ears. However, the rate of recurrence much lower. And of course, what's the third group? You can use a combination of these two. The cartilage molding, suture, with scoring, plus you may excise some cartilage using a combination. So others would maybe remove an ellipse in the concha just to assist in this. We call those combination techniques in a single otoplasty procedures. So how can we fix specific regions? Remember, we've identified the antihelix, we've identified the conchal bowl, and we've identified the earlobe. So how can we repair these? Now, perhaps we can start with the approach to an operation, so you have an understanding. It may be good to look at a couple of videos, but I'll take you through the general approach and what my personal approach would then be in areas that I present. But these have been spoken about in a lot of studies. For the antihelical fold, there's the concha scaffold suture technique by Mustadi. There's the antihelical scoring or autoabrasion by the Stenstrom. There's the antihelical excision by Luquette, Rogers. There's the conchal bowl. For the conchal bowl, there's the conchal mastoid suture technique by Fornes. There's the conchal bowl excision that's described by Davies. For the helical tail, there's the suture repositioning to the concha by Gullion and I'll remember his name, Conway. And then for the concha, and some may put skin excision and suture repositioning as described by Weber. And let's see how many more I can remember. For the lobule, there's posterior skin excision techniques. We'll speak about the incisions that you can do as defined by Levy and Stearns. And there's also other suture techniques where the lobule is sutured to the mastoid. So that technique described by Spira, Gozen, and I think it's Racinos. You will just double check me there. But Spira, Gozen, definitely, and I think Rosinos is the other name. But those are generally the techniques that are presented. Now, I will go away from the names because what's important is how you do the procedure and not trying to remember names. And the general approach, you would counsel the parents. If it's a child, you want this child to perform this under GA, makes things much easier. The entire head is draped, exposing both ears. You are able to see. So under GA, there are some who will operate adults without sedation just by topical local steroids rather that they would inject. However, I prefer my patients to operate them under GA in theater, and that's where I've got better control. Definitely local you will need, local anesthesia, and generally would mix that with adrenaline to just assist us. So xylotox with adrenaline works perfectly. You know your dose. You'll be looking at your doses there. Without adrenaline, 5 milligrams per kg, adrenaline 7 milligrams per kg. So generally, we want something like that: 0.5% bupivacaine with ephedrine 1 to 200,000 is what we are looking at, and this will assist us not only with analgesia, not only with bleeding, but also with hydrodissection, as you will see when we now approach this ear, the layers that we want to be looking at. Markings would be then the next step. And how do we do then the markings? Generally, you want to apply pressure medially to the helix. You have a look at the positioning where you'd want the ears to be, and by just doing that in itself, the future antihelical fold will immediately become apparent anteriorly. And so then you take a needle, 25 or 27 gauge needle, with methylene blue. You dip it in methylene blue, and generally where the antihelical fold shows itself, you would then on both sides tattoo, perform a full thickness tattoo to the post-auricular skin, because you want this methylene blue to be able to see it at the back. And so sometimes when you struggle, you may request your assistant to maybe, as the needle is right there at the back, to put the methylene blue again as you draw the needle back, and that will generally leave a tattoo. I like to go all the way around and define my entire antihelical fold. However, others would, you'd say as long as you've got 3 different points where you've marked it, you will be able to then identify it. And so now once we've marked our position, we will then mark our incision. And this varies, many people, some would say, look, and I find this easier, by the way, and that's my practice, to mark my post-auricular incision between the marks posteriorly. However, others have advocated, I've tried it, and I find it very difficult with the dissection, going to the retroauricular sulcus, and then going all the way. The undermining makes it a bit difficult sometimes, but it's something that can be done. The scar is better hidden, as others have claimed. And the type of incisions that you can do, as described, are the hourglass incisions, as by the Chong and Chen anterior technique. There's the dumbbell incision, the fishtail incision, the tennis racket, and generally I like to perform a fishtail incision, and you are able to then at least go much lower down and also address the lobule using that technique, and that's why I like it. And basically you'd carry down your incision, then you've marked it, you are able and ready to cut the patient. You've compared your methylene blue on the other side of the ears to make sure that you've got symmetry. And then in general, we then go and cut our incisions. We continue our dissection all the way to the raw cartilage, undermining, to expose the tattoo areas that we chose. And generally, that's where I'll start. I'll take it all the way from the top, and generally continue my incision all the way down, exposing that region. And so you then undermine, you've exposed it, and then you will decide what technique you're going to use. Now, if you're going to use suturing techniques alone, that's enough, that's sufficient. You then start your suturing there going. But if you're going to combine with scoring, and then you need to do a bit of more. And there generally are 2 approaches to scoring. Remember, as per the Gibson principle, the cartilage will fold away from your scoring. Therefore, the scoring will be done anteriorly in the anterolateral aspect of the ear. And so the 2 approaches you can continue with your posterior incision, the posterior approach, or it can be an anterior approach. The posterior approach, generally you undermine, you can incise the cartilage from the superior anterior helical crus all the way to the tail of the future antihelix. And then once you've done that, you then undermine and detach the skin anteriorly to expose the cartilage anteriorly, and then you can continue your incision of that cartilage in the direction of the concha, because what you want is to create that flap, that cartilaginous flap, in which then you will then perform your scoring. So that can be done. I prefer the anterior approach. The patients that I've operated, generally, you can hide that incision, is not a problem, depending on the healing of the patient. Of course, there are those with heloids, hypertrophic scarrings, of which we counsel the patient preoperatively. However, an anterior incision, much better. Others may go in the scaphoid fossa, or, you can just go the tail of the new antihelical fold under the antitragus. Works very well. And so you expose that area, you undermine, and you can score much easier, in a parallel and, cross-hatchet fashion. And then you would see the cartilage as you are doing that, folding away from your mark. And once you've done that, then we can go into the suturing techniques. We have mentioned that for the antihelix, you would then use, for your helical fold, you use your Mustadi sutures. The way you place them, I would encourage you to have a look at some drawings, but generally these are your metro sutures that you will then put. I use a clear nylon. You can also, use mescaline, but clear nylon 4O works well. And you put in there your sutures, and then you will tighten them, comparing the ears and trying to reach the angles. And remember, we spoke about those distances from the mastoid that you can try to target. And so you then tighten your sutures up to the point that you are happy with them. And so that's why you generally may have floating sutures that are there, not completely tied knot to knot. So those are the sutures you then put. For of course, you would then dress the patient with compression dressings, whatever your choice is. But generally for the next 3 weeks, you want the patient to wear elastic ski, bands, and just to avoid strenuous activity. Of note, just take care when you do this, not to iatrogenically narrow the external auditory canal. I've seen it happening, but just take care of that, and it's unlikely then to happen. For your foreigner sutures, these are the ones that you use for your conchal bone. So for the conchal bone, of course, we've used our incision, we've dissected, and what you then want for this, because the dissection, remember, using my incision goes further down, and what you want to do, you want to dissect medially and laterally to expose the post-auricular muscles and ligaments. And once you've exposed that, you will resect a segment of the mastoid fascia to expose the underlying peritoneum, periosteum, because that's what you want to grab with your sutures. And then people have a choice of what they want to do with the posterior auricular muscle. I generally cut it off, but you don't have to. Others don't. But as described, by foreigners, you would then cut that off. And once you've cut it, you then put in your sutures. You can use a cotton applicator to push the concha against the mastoid process, in assisting you, to make the markings before. And you want these markings at the juncture between the posterior concha and the mastoid process. That's where you're gonna mark, and then you will then put in then your sutures. Remember, I've spoken to you and told you the type of sutures that you can put. Generally you want the to grab the periosteum all the way down on the mastoid and put then the sutures through the fascia and the periosteum and then through the cartilage in that direction. What's important, of course, after that is you want your bolster, basically bolstering the posterior or the medial concal, repositioning there, and they similarly to keep these elastic ski band continuously for the next 3 weeks and avoid strenuous activity. So those are the techniques that you may use to then fix this. The Mostadi, the Fornes, and we spoke about the how you would go about in terms of scoring your cartilage. And this should suffice. 2 or 3 of the sutures should be enough in order to achieve this. And of course, you want to achieve it and getting it to the right side. And then, of course, the lobule. Generally, the lower third in the lobule, I find it easier to correct using the modified fishtail excision, the Woodsmith. And that generally does the work. You mark that V extension just, from the inferior aspect of our postauricular incision. And this should correct then the ear. You will compare with both sides of the ear and make sure you transpose the markings to the mastoid skin. While actually that ink is still fresh, to form a mirror image in the shape of that fishtail. The other ways you can do it, alternate ways, others may also for the lobule decide to suture the actual lobule to the mastoid. Generally I don't do that, but you can also do that. It is described to address the lobule, and generally those are the ways that you would then correct a prominent ear. Now, let's perhaps just spend the remainder of this session just looking at the complications that may follow, and I may ask you a question to say, look, discuss the causes and complications that might lead to a revision orthoplasty, and we may say, how would you correct each of these complications? And so generally, whenever you ask about complications, we divide them into early complications and late complications. What are the early complications that you get? And hematoma, of course, we don't want a hematoma. That's the most immediate and pressing post-operative problem that, we usually get. And you can get a guide from the patient if suddenly, they have this sudden onset of persistent, maybe unilateral pain, then you must suspect a hematoma. And generally, you don't want to play. We don't want a cauliflower ear. We remove the dressings. We may need to remove sutures sometimes and evacuate this clot and reapply the dressings with mild, compression. And generally, you take this patient to the operation room if you have to, and re-explore, using hemostasis and achieving that. Others are infections, which is rare, quite rare, I must tell you. Usually they'll be from, Staphylococcus or, strep. Occasionally Pseudomonas. But sulfamylon, useful in preventing the spread of the infection. And generally what we don't want is chondritis. Chondritis is the surgical infection that's going to require prompt re-exploration. We don't want to play with this, and we want to then go in if we've got chondritis and excise the necrotic cartilage. So those are some of the complications that we can get. What are some of the late complications and general complications that we get? Most commonly would be suture complications, and these are related to suture extrusion in the postauricular sulcus. And such sutures, they easily removed, but remember they may be associated with quite an unattractive, or at times even painful granulomas that you may get there. And we've had to remove a couple of granulomas, certainly. Let's look at some of the controversy, maybe some of the things. Monofilament sutures, great to use, but they will tell you, look, they're less likely to form pustules or granulomas when protruding through the skin. However, we know they will require more knots, and they may be more likely to protrude through the skin in the first place. So some of the arguments, some things that you must just have in your armamentorium. And then some complications are late deformity. We know recurrence usually manifests itself and within the first 6 months of surgery at times. And generally what I found is these are more often operator dependent than technique dependent. There are numbers, maybe you may know. 10 in his study, he found 24% of patients undergoing the Mustadi technique required reoperation, and 10% of patients undergoing the Stenstrom technique, the scoring techniques, they required reoperation. And reasoning, what they found is that, look, the presence of sutures in themselves resulted in sinuses and wound infections in 15% of the patients. And what they found with cartilage breaking techniques, that they leave more sharp edges, as I've mentioned, and conquer, irregularities than compared to the cartilage breaking techniques. And generally, that's what, it's undesirable, but decreases the recurrence. So as a tip, perhaps you may want to break the ring of cartilage, just, to prevent some deformities. A telephone ear deformity is something else that may come out. But generally, those are just some of the arguments that I brought. So perhaps just a few tips that one may give as per the incisions. The arguments, just know about it. Others would say best place in the retroauricular sulcus, not up to the back of the ear, but just know that up to the back of the ear is more convenient. For the surgeon, it makes the operation go faster. Certainly, I found, but it may leave a scar that is visible when the patient, is viewed from behind. But I found that approach to work well. I do both. I've tried both, but you certainly just know that skin excision. It's really what we found. It's really unnecessary. It's really unnecessary to excise skin. It does not contribute to the correction. And in fact, that in itself with the strain may lead to hypertrophic or undesirable scars. So certainly only, exception may be the earlobe where it may be necessary. But when you do perform that, just, take care to remove just only enough skin adjacent maybe to the retrolobular sulcus, just to allow repositioning and to leave a full earlobe, because patients may want to pierce their ear lobes, and so if you excise too much, I think they end up with an aesthetically abnormal earlobe. And generally, we've established it's unnecessary. But in your approach, the simplest techniques are the best. Don't complicate life. And techniques that involve abrasion or full thickness incisions or tubing to create the helical folds, I find that they are unnecessary and generally should be avoided. Take care not to overcorrect, or undercorrect, but the advocation would be overcorrection of the ear is actually what's found to be the most common problem, of course. But you should always try not to overcorrect these patients. And the aim, at least what one would advocate for, is that the contour should be soft. It should be round, natural, rather than sharp, and it look looking like the patient actually had surgery. I think that's the things we want to avoid. And I think this should cover prominent ear. By this, you should be able to tackle a prominent ear, understand a prominent ear, and what to then mention. Perhaps in our next talk, we can look at other ear deformities such as anosia and microtia, what we can then do for those patients, the brand techniques that have been, introduced there, etc. We'll have a look at those, and perhaps we can also look at a constricted ear deformity. Look at other ear deformity, a bat ear, a lobe ear, a cup ear, cryptotia. What do we do for these patients? And our severity spectrum in a constricted ear, and what Kuzman, advocates for in correcting these patients and what we can do for them. I think this should be enough, and I thank you for your attention. We'll have a chat next time. Take care and goodbye.